Good afternoon. Hello. Hello, all. Hello. Good afternoon, everyone. Hello. Yeah, no problem. Yeah, problem. The default element. Default element. Understand. Hello, all. Very good afternoon and welcome you all to a session.
టోటల్‌గా వాయిస్ వస్తుందా ఇప్పుడు?
Good afternoon, everyone. So I welcome you all to this session and apologize for the technical glitches that we had gone through. So before we start the topic proper, let me introduce myself. I'm Dr. Chandra Sekhar, Senior Consultant Critical Care at KIMS-Saveera Hospital, Anantapur. So introduction to intensive care unit. So this is intensive care unit is something which most of us encounter during our lifetime, maybe through our relatives or friends, or sometimes sometimes you encounter, you talk to a doctor and they speak some technical terms regarding the patient in the ICU. So there are some common points and some very simple things that you need to know about the ICU. So I'll put it very simple, and this is going to be for mostly useful for the general public and somebody who's new to the medical field. So what is an intensive care unit? Intensive care unit, also called as a critical care unit. So there are several terms and several types of ICUs. So what is it? Basically, intensive care unit, by definition, it's a specialty department of the hospital which takes care of severe or life-threatening illnesses. So any patients with life-threatening illnesses requiring support systems like either a ventilator or a dialysis machine or any other support system like simple oxygen, and requiring one or two organ supports. So all such patients are kept in the ICU. So there are several types of ICUs that we know of. There are medical intensive care units where patients are mostly related to somebody having severe fevers or infections. There are respiratory critical care units, which are problems related to the lungs. There are cardiac intensive care units. There are which are related to the heart. Cardiac basically says something about the heart. So, and there are other types of intensive care units like the geriatric intensive care unit and the neurosurgical or the neurology intensive care units. That is, patients with severe head injuries or severe strokes. So, like this, there are different types of intensive care unit. So, intensive care unit is also called as a critical care unit. So how is it different from a ward? So when you see ward, there are a lot of differences between the ward and the intensive care unit, starting from the infrastructure, starting from the way it is designed, starting from the AC units, and starting from the staffing pattern. So all these things vary between a ICU and a ward. So in an ICU, it's always an integrated team approach where you have a team of specially qualified and trained doctors called the intensivists. You have nursing, paramedical staff running round the clock. The paramedical staff include the respiratory therapists, the physiotherapists, the nutritionists, and also supporting staff who constantly help you in mobilizing the patient or who constantly help in keeping the patient clean. So apart from that, you have in an ICU compared to a ward, you have better nurse patient ratio. You have qualified duty doctors around the clock who take care of monitoring the vitals around the clock, and you have specialized equipment also, like you can do a continuous BP monitoring in intensive care unit with an invasive blood pressure line, and you can do a continuous monitoring. So, what group of patients require an ICU? I think this is something which is known to everyone because you commonly come across elderly patients with these kinds of illnesses, especially the heart attacks, the brain strokes, or anybody with severe infections, say lung infection or urinary tract infections, or somebody who is in multi-organ failure. So failure of more than two organs at a time is considered as a multi-organ failure. It can be simply like platelet dysfunctions, liver dysfunctions, and it can be kidney failures. So all those patients who have more than one organ failure and severe head injuries. Somebody who met with a road traffic accident, or somebody who had an assault, or something like somebody who had polytrauma injuries to multiple organs. So all these complications are usually the category of patients who require intensive care unit right from the beginning. And apart from this, there are most of the times we get poisoning cases and severe fevers, especially the tropical fevers, which usually present to any ICU with severe symptoms of sometimes patients may present with altered sensorium where they won't be able to speak properly. They'll be having slurred speech. They'll be having difficulty of speech, and sometimes they come with very early signs of kidney failure, like the drop in urine output or no urine output, or they come with complaints of severe pain abdomens, diarrhea, vomitings, and all such things. And another most important category of patients are the pregnancy and the pregnancy related complications, especially the peripartum period, means the period around the pregnancy, before and after the pregnancy. So before, during, excuse me. So we have important complications like the peripartum cardiomyopathy, means the functional ability of the heart comes down during late pregnancy. So that is called a peripartum cardiomyopathy, or stroke during pregnancy, or some amount of blood clots during pregnancy, or death of the baby just prior to pregnancy or during pregnancy. So all such complications are also usually seen in the intensive care unit. So levels of ICU. This may not be particularly important for all of you to know, but the important things is when you're visiting any hospital, you have to ask what level of ICU they have, because level 1 ICU basically caters to only very simple patients who are probably who were kept in the larger ICU, say somebody getting referred from a big super specialty hospital to a small hospital nearby. So where they are already treated partially, and they need just simple supports like oxygen support, or they just need close monitoring. So those kind of patients come to level 1. Level 2, they might require interventions like oxygen delivery devices like the BiPAP or HFNCs, or ventilator support for a short duration. Level 3, they will have multiple equipment for supporting the organ systems, the complete organ systems like the heart, the lung, and the kidneys. So heart, basically, they can have an IABP machine, they can have pacemakers, and for the lungs, they can have ventilators, then followed by ECMO machines, the highest level of support for the lungs, and the heart as well. And with regards to dialysis, they can have dialysis machines, and in the dialysis machines, they can have the advanced dialysis machines like the CRRT, SLET, and hemodiafiltration machines. Along with that, they have all the equipment, including the continuous monitoring of blood pressures, continuous monitoring of the oxygen uh, dependency of the patient, as well as several other monitors that we are going to discuss shortly. So this is must ask when you are visiting a hospital. You have to ask their level of ICU care, because you never know which patient goes bad when. So when you're taking a kith and kin, always check whether the hospital that you are joining has what level of ICU care and how much can they support your patient in case of an untoward event. So the level of ICU is also categorized by other parameters like the staffing ratio, the nurse-patient ratio, and things like the minimum number of beds. So in level 2 and level 3 ICUs, which are important to us, we have a continuous monitoring by intensivist and their complete team. So who is an intensivist? I'll let you know shortly. So you have the complete responsibility transferred to a specialized doctor called an intensivist or a critical care physician, somebody who takes care of such critically ill patients. And you have them round the clock, 24/7, and they are available through the week. So apart from that, you have something like uh, the ratio here, the intensivist staffing, that is a full-time employee. FTE means a full-time employee. So 0.1 to 1.5, 0.15 reflects a doctor for every 10 beds. So in case of level 3, usually you require a doctor for every 5 beds. So intensivist, there will be for every 5 beds, there should be one intensivist for a level 3 ICU. So you want the person who is taking care, especially the intensivist, to be concentrating on very few number of patients with utmost care. That is when you get the best ICU results. So you should ask the level of ICU care. And the other important staffing pattern that we should know is the nurse staff, because not only do the doctors have a role, the nurse has, in fact, to accept on an open stage. Nursing is probably one of the most competent authorities that is required in the intensive care unit, for especially for good patient recovery. So you require a full-time employee for 4.2 full-time employees for each bed. That is because the round-the-clock services, nursing goes on round the clock. So in a tertiary care ICU, how we usually pattern is 1:1. So 1:1, that is accepted even by regulatory bodies and the national NABH and the JCI standards. So 1:1 for the ventilatory patients, and for the regular ICU patients, it is 1:2. So that is one nurse for every two patients for a non-ventilated patient, and one nurse for each ventilator patient. So in a level 2 and level 3, usually the maximum number of beds that can be kept is around 12. So 12 beds per ICU, along with two intensivists and 1:1 nurse ratio for a ventilatory care. Along with that, the other important staff that are required, as I've already told you, the respiratory therapists, the IMRs, and the regular ward boys, who help us in mobilizing the patient, who help in keeping the position of the patient all the time, because you cannot just make the patient lie down flat. You have to just keep changing their position. So, like I've told you, an intensivist is, or a critical care person, is a person who gets a specialized training in intensive care medicine. So, basically, they finish their master's degree, and after that, they get trained in intensive care uh, by a board certified or board certified training, and they take the complete responsibilities of the ICU. So usually they do a master's in either anesthesia or internal medicine or pulmonary medicine, and then they get an additional fellowship. So how are they different from other physicians? They're different in the sense that, say, they concentrate on a broad spectrum of organs rather than restricting themselves to a single organ, and they are in integrated approach with other departments to have a solid plan for the patient. So suppose if a patient requires angiogram, they tend to get in the cardiologist, discuss with them, so and get the best out of take the inputs from the cardiologist, get the patient treatment done, and then coordinate with the other things like what are the complications that we get. Like suppose you do an angiogram, there might be sometimes complications like contrast induced allergies, there might be complications like excessive bleed. So all these things are taken care of by the critical care physician after the cardiology part is done. So these are the important things in a ICU, especially when you are looking at tertiary care ICU or ICU of a large hospital. So 4 points to remember: ideally 12 beds and not beyond that, and one intensivist for every 5 beds, and a trained intensivist, along with adequate nursing staff. So this is how broadly an ICU room looks like. This is an isolation room. So we have labeling for each. So we have the multi-parameter monitors. We have a dialysis machine on the extreme left, we can see. And there are something called syringe pumps, infusion pumps, fluid warmer that warms the fluid, and the pendants. So what does the pendant do? The pendant contains all the pipelines and the necessary pipelines, mainly the vacuum and the oxygen and the medical air. So all these travel through the pendant, and they are connected to the ventilator machines, which are there connected to the pendant. So along with that, there are multi-parameter monitors. There are patient bed, which can be adjusted. It can go in multiple directions. Like you can increase the head height, you can increase the limb height. Then you can also do a head end elevation and a foot end elevation. So next, coming to what are the common monitoring that we see in the ICU. So when you walk into the ICU, you see this monitor going around with lots of waves in it. So the things on this. So this is a standard monitor that most of the ICUs have. So it looks like this. So what it starts with, the top one is the ECG, and these may not be in the same pattern. Somebody who would want to monitor the BP, they can change like BP to the first line and ECG to the second line and respiratory to the third line and so on. So this configuration can be changed, but the parameters usually will be the same. Like you have the ECG along with the rhythm. So the one on the 80 indication here is the heart rate, and the ECG waveform. So whether it is regular, irregular, and what is the rhythm that is going on. Then the respiration. So how many times is the patient breathing per minute? It can be set by a ventilator or the patient's own breaths. And the next one is the SpO2. I think this is one point which almost whole of the world knows now, thanks to COVID. So when we used to put a probe on our finger and check it, and now most of our mobile apps also have an SpO2, so which indicates how well our tissues are perfused and how the oxygen saturation is. Then end tidal carbon dioxide levels. This most of the times it's an additional monitor, so that helps in checking whether the tube, whatever we are putting through the mouth and connecting to the ventilator, whether the tube is in place or not. That helps us in monitoring, and also it helps us in keeping the carbon dioxide levels in check. And the next one is IBP. IBP is nothing but invasive BP. So there are, when you're checking the BP, what we regularly check at our homes. So that is a non-invasive BP. So you're not actually pricking anything, or you're not actually introducing anything into the body. Whereas in an invasive arterial BP, so you are placing a cannula into the one of the arteries, like the radial artery in the hand or the femoral artery in the leg. So once you place that, you connect it to a system transducer and then to the monitor. So the monitor shows you the blood pressure for every beat. I'll show you the configuration very shortly. The next one is the NIBP, that is the non-invasive blood pressure. So non-invasive blood pressure is how we tie the cuff. So this is a monitor with all its wires and gadgets. So you see one is the NIBP cuff, what we regularly use, that is tied to the patient on the right side. And then the saturation probe, the clip kind of a thing that is being shown in the picture, and the ECG leads. So the ECG leads are put on the patient in 3 or 4 places, depending upon the parameters and the leads that you want. So they are connected to the patient, and the doctor starts analyzing the rhythms. So this there will be a lot of alarms on the ventilator. So whenever there is an abnormality, if you have kept the range, say suppose you have kept the heart rate between 60 to 100, and you want an alarm beyond 100, so after once it crosses 100, it gives a alarm. So these are all the gadgets that are attached to the patient in the ICU. So like I've told, an invasive line, unlike the cuff that you are seeing in a non-invasive, so you are putting a cannula into the radial artery. So this is the hand. This is the hand of the patient. So where we are introducing into the a cannula into the radial artery. So this radial artery cannula is connected to a series called with the transducer and a pressure bag, and then finally the reading of IBP comes on the monitor. So this is apart from what I have told already now. So there are other monitorings in the ICU like the urine output, the pain score, the Glasgow coma score, and the fluid intake, pupillary reaction, and the pressure ulcers. So there is a standard ICU chart in each hospital. So this is our hospital ICU chart. So there are things to be filled every hour. It's divided in a 24 hours pattern. So if you see it closely, I'm sorry for the image, but if you see it closely, there is a 24 hours chart. So every hour, the nurse or the duty doctor keeps filling all the data, including what are the drugs that are given to the patient and the common parameters that we have assessed now in the monitor. You had 6 parameters that we have assessed. And then apart from this, how is the urine output? If you are putting a catheter into the patient, so how much urine is he passing per hour? Then pain score, does he have any pain? Suppose a patient with any injury or a patient with any pneumonias with cramps and all those things, does he have any pain? And another thing that we commonly monitor is the GCS. So GCS is one score which you should remember. So this score has numbers from 3 to 15. So 3 is if somebody is in deep coma, and 15 is somebody who is fully alert. So we scale 3 things in this. One is the eye opening, whether the patient is spontaneously opening his eyes or not. The second one is the motor response. So if you ask him to shake his hands or if you ask him to lift his hand, is he lifting it properly? So that means he is doing it adequately. So you have numbers like M6, M5, M4, M3, M2, M1. So this instead, to make it easy, most of the monitoring charts have the score written beside, so the sisters can properly check that and write the score properly. So if somebody is with a GCS of 3, then you consider they're in deep coma. So another thing is pressure ulcers. So ICU patients commonly tend to develop some kind of ulcers. So on the backs where there are pressure points. So pressure ulcers are also noted as to what is the depth and what is the area and how many days is it and what is the precautions taken. So next, moving on from monitoring, the next thing is how do we deliver oxygen in the ICU? So there are several means of delivering oxygen in the ICU. Like you have the simplest, the one on the extreme right, that is a nasal cannula. So where you just put 2 small cannulae into the nose and then you simply deliver oxygen. The other one is a simple mask, then a Venturi mask, which you can set the FiO2, and then the last one is a BiPAP. So in the picture, you can see the lady here with a BiPAP. So this can be used at, there are certain machines called the home BiPAPs also. So this can be used at home also after getting discharged from the ICU. So what are these various types of devices and how are they selected? So what do we usually do is whatever oxygen percentage that we are breathing in the air is 21%. So considering the fraction of inspired oxygen to be 21% in the air. So depending upon the patient's oxygen requirement, we choose the device, which device to be given to which patient. Suppose if the patient is requiring only about 30 to 40%, so and he's comfortable, then we try to go with the nasal cannula. And suppose the patient is requiring slightly higher, say 40% to 45 to 50%, then we'll go with the simple mask. A little higher, up to 60%, then we go for a Venturi oxygen mask. Beyond that, either we go for a HFNC or we go for a BiPAP mission. So this is a HFNC. It's a relatively newer mission, and post COVID, its use has been very much increased. So probably the use and advantage of it. This is the mission. This is how it looks. So it's a very you call it big things come in small packages kind of a mission. So there is a soft cannula, so, and it's all rubber textured. So it's very non-irritant and it's very simple on the patient. So this is how it is attached, and the we can set the oxygen gas flow as well as the fraction of inspired oxygen that is required for the patient. So this is much comfortable in terms you can deliver a higher flow oxygen, and you can deliver a higher concentration of oxygen with minimal irritant to the patient, like unlike keeping a tight mask to his face or putting him on a complete ventilator. This is a device which helps in delivering better oxygen. So the next one is intubation and mechanical ventilation. So a mechanical ventilator is a device which provides complete oxygen. So it takes care of the complete oxygenation of the patient and the ventilation. So ventilation means it gives in oxygen. It takes out the carbon dioxide also. So it is responsible for maintaining both the oxygen as well as the carbon dioxide levels. So how do we achieve this? So before we put the patient on a mechanical ventilator, we have to intubate him. Means we have to send a tube through his vocal cords into the lungs. So in the picture you can see the vocal cords, and that is the laryngoscope. So that is the scope which is introduced through the mouth, and from after visualizing the vocal cords, a tube is passed through the vocal cords into the lungs. So once the tube is passed into the lungs, the tube is secured, then it is connected to the ventilator. So as you can see in the picture depicted over here, so the tube is into the lungs, and once it starts ventilating, there are two arrows: one, the inflow of the oxygen, and the second, the outflow of the carbon dioxide. So this is how a ventilator mission looks, and this is how the air keeps flowing. So air pushes into the patient, and the exhaled carbon dioxide goes out of the patient. So this is pretty much how oxygen is delivered in the ICU. So how do we deliver the drugs? So how is the medication given? So medication can be given most of the times. There are multiple routes of giving medication. You can either give it through the vein, or you can give it directly into the muscular, or you can give it subcutaneous. But the most common thing that we do in the ICU is the venous line. So we tend to put a cannula. So this is how a cannula looks. So most of the people, as soon as they see the cannula, they get scared that we are putting some steel thing into their body. No, it's not. It actually has a plastic sheath over a steel needle. So this thing is called a catheter. So it's over the steel needle. So once we insert it into the patient, we actually remove the needle. So there is no steel kind of a thing inside the vein. And once it is secured, it looks like how it is. And these are the extensions. So we can keep an extension to that, and there's a extension three-way. So to look, it looks very cumbersome, but it's actually a very small and a simple thing which is kept introduced into the vein. And the amount of use, probably this is the most useful and the simplest equipment uh, probably ever in medical equipment list. So the other way is, if we don't suppose the patient is standing for a long time, and patient has been in ICU for more than 10 days or 15 days, and there were multiple pricks, or he's completely emaciated because of lack of nutrition. So then we try to pick up a central vein. Central vein is, you try to locate a big vein, probably with an ultrasound. So what we do is we put an ultrasound probe, vascular probe. Then we check the flow in one of the major veins. If the flow is good and the vein is identified properly, then with the help of a needle and an introducer again, we keep a central venous catheter. So the central venous catheter can be kept safely, and there are one advantage is you don't need to prick multiple times, and there are some drugs which are irritants when you give through the small veins. So something like potassium or insulin or calcium. So when we are required to substitute patient with some electrolytes or patient with some high alert medications, so most of these medications tend to irritate the small veins. So a central venous catheter has that advantage of delivering it without any damage to the vein, without causing any swelling on your hand, or without causing any reddish discoloration of your hand. The central vein helps a lot in that. So there are multiple sites where we can place the central vein, like the subclavian vein. The one shown on the left is the subclavian vein. So there is a internal jugular vein, there is a femoral vein, and there are other sites also which are less commonly used. So how do we feed the patient in the ICU? So we commonly allow the patients who are who are in full consciousness and who do not have any breathing difficulty, then we allow them to have oral food based upon their condition. We might have some restrictions with relations to their sugar, so diabetic diet, renal diet. We have separate diets for each, again specially designed and customized for the patient by the nutritionist team. So apart from patients who are not able to eat by cells, so then we put a nasogastric tube. So what is a nasogastric tube? Nasal is through the nose and a gastric is to the stomach. So a nasogastric tube is something which is introduced through the nose and enters into the stomach. So once you put the tube in, you confirm it with a syringe, or you can confirm it with an X-ray, because the tube has a radio opaque line which is easily seen in the X-ray. So once it is confirmed, then we can use a syringe or a continuous bag and keep feeding the patient. So the nutrition, the amount of feed that is sent is calculated, and the calculated feeds are sent through the nasogastric tube. There are other means, especially in patients who have esophageal cancer, or patients who are long-standing cancer patients, or patients who require very long times of Ryle's tubes, or some severe poisonings like the corrosive acids, where the upper GI tract is completely damaged. Then there is something called gastrostomy, where a tube is directly introduced into the stomach. This procedure is done inside the operation theater. And there is another called the jejunostomy, the feeding jejunostomy and the feeding gastrostomy. So I would like to keep this session a little short. Probably I'll end it now. But I would like to continue this session again. I want to talk more about equipment like the dialysis machine. Then we'll talk a little bit about the ECMO. And as I've introduced nutrition to you, I would like to tell you how we calculate the nutrition, how the patient gets the nutrition, and how do we analyze the day-to-day parameters, like how do we send the investigations on a daily basis, and how do we say whether the patient is going good or going bad. What are the common parameters that we discuss with the patient and attenders to see what is going on. So with this, I'll end my session. Thank you very much for joining me. Thanks for now.